Welcome to our live stream, NICU Orthopedics, a world unto itself. Thank you for joining us. My name is Ryan, and I will be the operator for the presentation today. We are joined today by our speaker, Dr. Sarah Stelma. She is a board-eligible pediatric orthopedic surgeon with a subspecialty interest in scoliosis, trauma, fractures, and adolescent sports injuries. She has published numerous articles in medical journals, publications, and textbooks, and has presented at medical conferences and medical schools. Dr. Stelma is on staff at the Pediatric Orthopedic Center in Cedar Knolls and Wayne, New Jersey. At this time, I would like to turn the microphone over to our speaker, Dr. Sarah Stelma, for opening remarks.
Great, thank you. Hello, everyone. And I will be talking about pediatric orthopedic issues that you may find in the NICU. Okay, so an outline of what we're going to go over, how to do an ortho baby exam. And then the other topics include infection, so in osteomyelitis and septic joints, hip dysplasia, foot deformities, including clubfoot, congenital vertical talus, and toe deformities, trauma, so fractures and brachial plexopathy, a few spine topics, torticollis, congenital scoliosis, and infantile scoliosis, and a knee dislocation. So a lot of topics, but I'll go over each one a bit. So how to do an orthopedic baby exam. So it really first starts with inspection. So looking for any skin lesions, any patches of hair on the lower spine, any dimpling over the spine, looking for nevi or moles or skin abnormalities of any kind. I'm looking at the shape of the head. I'm looking at the range of motion of the neck and all joints of the extremities. I'm also looking for symmetry from side to side. I look at the feet for any obvious deformity, the ankles, the shape of the foot, the position of the toes. Looking at tone to feel if the baby is hypotonic or normal tone or spastic. And then also looking at reflexes, so the abdominal reflex, the Babinski reflex, which is abnormal in babies, which is normal for them, so an upgoing Babinski, and the Moreau reflex. So the first topic of infection, I'm going to go over septic joints and osteomyelitis. In this right X-ray, you can see that osteolysis near the growth plate of the distal tibia, and that's a picture of osteomyelitis where you can see the lytic lesion. So infections like these are rarely fatal, but they may be associated with long-term sequelae. And I'm borrowing this quote, suppurative infections of the skeletal system still present challenges since these illnesses are often difficult to recognize and localize early in the course of illness, and many are difficult to manage medically and surgically. In spite of our best efforts, a substantial portion of those treated are left with disabling sequelae. So even from experts in the past, this is still true today, that it's very difficult to recognize and it's difficult to manage, but we will do our best to mitigate those sometimes disabling sequelae. And musculoskeletal infections are really a spectrum of disease. So the number of areas that are affected can increase, and that increases the severity. Along with this, they may have elevated lab values. There's stay in the hospital is longer, may need more surgical procedures, a longer stay in the ICU, and also increased risk of a DVT. So going from the bottom of that list, just an abscess, increasing in pyomyositis, septic arthritis, osteomyelitis. So the infection can be in a number of areas. So who gets these? More kids in the first decade of life. The mean age is about 6 years, so a bit older than the NICU, but including the NICU children. It's about 1 in 5,000 in kids less than 13 years, and it is skewed more toward boys than girls, 2.5 to 1. And on the right, that's a picture of osteomyelitis throughout the humerus, and then you can see the suppurative infection around in the soft tissues. So we can think of these infections in really 3 different groups. So infants less than 1 year, children over 1 year, and adults. So it affects each age group slightly differently. And what are the risk factors? It is common in healthy children, so there aren't necessarily other risk factors, but certain aspects of a host does put them more at risk. Anything that impairs the host resistance, so prematurity, sickle cell disease, any reason for an immune deficiency, if the child has any malignancy or is undergoing any chemotherapy, diabetes, a chronic renal disease, varicella infection, and juvenile rheumatoid arthritis. So how does the infection get in? Most often it's from a hematogenous seeding from a different site, so an infection elsewhere in the body, and then it spreads to the bone. There could be a direct inoculation, such as some sort of trauma, local invasion, so adjacent soft tissue or bone infection. So an infection started as an abscess and spreads to the bone, for instance, and iatrogenic, so anything that happens in the hospital, and that can be even related to like a direct inoculation, but in the hospital setting. So how does it spread? So this is on the right a schematic of a pediatric bone. So at the circle at the top, there's the growth plate with those chondrocytes, and the character of the blood vessels changes throughout the extent of the bone. So first the bacteria would enter through the nutrient artery into the bone, into the medullary space, and then the bacteria localize in the metaphyseal veins. So where the blood vessels get a little bit smaller, and then finally in the vascular loops where the blood vessels are the smallest, and that's where the bacteria localize. In infants less than a year, they have rich periosteal vessels, and any sort of transient damage to that surrounding periosteum around the bone can cause that involucrum, or that basically to push the infection into the bone, and it develops more there. And that's a drawing of that involucrum in the middle of the bone and that rich periosteal space around it. And on the right, you can see two pictures of an infection in the bone. You can see it on the tibia in the top picture, that osteolysis, or the wearing away of that bone. And along the side, you can see that periosteal reaction, like a halo around the bone. And then in the bottom picture, you can see even more of that periosteal reaction. So why does it affect infants differently? So there is a risk for permanent epiphyseal damage. So where those blood vessels are in that infection can spread and affect the growth plate itself. It can cause irreparable growth arrest. So if it damages completely that growth center, then it doesn't come back. That end of the bone won't grow, except for from the periosteum, but not from the end. It can spread into the joint. So that anatomy is a bit different too. The blood vessels cross over into the epiphysis of the bone, and that can, in certain joints in the body, it's more likely to spread into the joint. And if the infection does spread into the joint, that can cause permanent articular damage within 8 hours. So that really is an emergency. And you can see in the histology pictures on the bottom that the outline of the blood vessels that go across the femur, the proximal femur, the femoral neck into the femoral head. So there's no separation across the growth plate, the blood vessels. These are some pictures of some very negative effects of osteomyelitis. So the bone destruction and the limb length differences in the destruction of the joints. So on the left picture, you can see the different lengths of the bone, and also proximally you can see that the left hip joint is very destroyed. In the middle picture, you can see the mottled appearance of the bone with that periosteum around it. In the right, you can see really what happened to be a hip fusion in a very abnormal position. And then on the bottom, you can see two pictures of osteolysis, so really obliteration of the normal hip joint. So in neonates, so 0 to 2 months, they have a really immature immune system, and they're more at risk for any foreign body inoculation by multiple lines, and they could get MRSA infection, Candida, etc. from those multiple lines. They may exhibit poor feeding, irritability. They may have very labile temperature, and they may actually go into fluid sepsis. We do typically get labs. They can give us a lot of information. Sometimes they're unreliable, however, and they may not develop a fever. But also in these babies, 30% have multiple sites of infection because it's contiguous spread from other sites. And in 70% of these kids, they're premature. So prematurity has a big risk factor for them. A third of the cases have osteomyelitis and septic arthritis, and that is related to the anatomy of different joints, that metaphyseal region with those smaller blood vessels is already into the capsule of the joint. So if the infection doesn't really have to spread across the growth plate, in this case, it can just spread out from the metaphysis into the joint. And that is in the proximal femur in the hip, the proximal humerus in the shoulder, and the proximal radius in the elbow, and in the distal lateral tibia in the ankle. And different microorganisms affect the different age groups. Typically, across all age groups, Staph aureus is the most common, but in neonates, we also think of group B strep and gram-negative bacilli. In infants 2 to 18 months, still again staph, but also strep pneumo, group A strep, E. coli, and Klebsiella. In older school-age children, salmonella and gonorrhea are also on the list. So there can be a history of pain. It can be constant or well localized, obviously not in the very small children, but that may not be the main complaint. If they're a little bit older, they may refuse to walk, or there may be a limp. But really in the neonates, they refuse to move an extremity. There may be a referred pain, so a whole area may be uncomfortable. There can be a history of recent trauma, and 30 to 50% of kids have a recent or concurrent non-muscular infection, so some other contiguous spread from a different site and a different reason for an infection. Other things, again, prematurity, asthma, other reasons to be on steroids or other immunosuppressant drugs. And if they were on previous antibiotic treatment, so either an incompletely treated infection or something that is a little bit more resistant. What do we look for? So low-grade fever. Overall, does the child appear ill? Are they irritable? Are they lethargic? Are they refusing to feed? Are they tachycardic? And then looking at really the extremities, they typically hold an extremity in the position of comfort. So is again looking at asymmetry. Are they holding a limb differently? Are they refusing certain motion of one of the joints? Is the hip irritable? Are they not moving a knee? Are they not moving an arm symmetrically? And this baby on the right, they're not really moving that right arm. It just stays at the side, even when they're trying to touch their face, they use the other arm. Other things to look for, signs of inflammation, so erythema. Is there obvious swelling? Does it feel warm? And then, as I said about the spontaneous movements, what are they naturally doing and what are they resisting? Guarding or pseudoparalysis, so does it look like they're just not able to move a limb? And then it may be from the pain of the infection. So fever and any tenderness over a bone equals an infection until proven otherwise, so it definitely needs to be included in the differential. There are other things that can look like infection. So any trauma, so if something's broken, they may not move a limb as well. It may be a little bit swollen. It may feel warm. Sickle cell disease can be a reason for bone pain. A bone infarct is an idiopathic dying of the bone. It can have an abnormal appearance on X-ray as well that can mimic infection. Caffey's disease, which is pictured on the right here, which is infantile cortical hyperostosis. So you can see that periosteal reaction around several of the bones in the limbs of this child. Gaucher's disease, syphilis, malignancy, so all mimickers. So infection should be on at least the differential. There are several neoplasms that can mimic infection. And so some of it, leukemia, osteosarcoma, Ewing sarcoma, can have similar or overlap of symptoms with acute osteomyelitis. If something appears to be in there for a little bit longer and looking more subacute, it can also look like chondroblastoma. And then if it's looking a bit more like chronic osteomyelitis, that can also appear similar to primary lymphoma of the bone or metastatic neuroblastoma. And then there's other different features that go along with each of these, and also other lab values that can be used to differentiate between these. So we start with imaging, x-rays first, but the earliest finding is just soft tissue swelling. So the bones may appear normal if we're catching it early. The periosteal reaction shows up at about 5 to 7 days, but the osteolysis, or that lytic area of the bone, doesn't show up until about 30% of the bone is lost, and that is later at 7 to 10 days. So the x-rays may not give us a lot of information initially. Other things that we can get are ultrasound, especially for looking at hip infections. They can identify subperiosteal abscesses, and they're not always as sensitive. So if it's negative, it shouldn't delay aspiration if it's a high enough clinical suspicion, but it's definitely a useful tool, especially for hips. MRIs are also very helpful. They can also show us whether it's osteomyelitis or other deep infection, or if it's a pyomyositis with an osteomyelitis, just like that, the spectrum of disease chart. So really identify the full spectrum of where the infection is, and especially helpful for infections that are throughout the pelvis and the spine to see into those deep areas. The MRI also helps guide a surgical approach, and the sensitivity is increased with gadolinium. So we do want to get MRIs with contrast. CT scans can also be helpful. We may see some gas on the CT scan. It may help show where the sequestrum is, so if there's a dense area inside of the bone where the infection is, and also for later disease, in thinking more like chronic osteomyelitis, the CT scan can also be helpful. A bone scan can also be utilized, especially if the site is unclear, or to evaluate for multi-site involvement. Sometimes more helpful in the infants, where it can especially be multi-site involvement in those premature kids. It can differentiate between osteomyelitis and cellulitis. It's more specific and not very specific, and there is a false negative rate. There's another gallium labeled leukocyte bone scan. It's more expensive. There's more radiation. It does take longer, but its accuracy can be increased following a negative bone scan. And then there's also an indium scan that is more accurate, and it's typically utilized for more chronic osteomyelitis. And in the pictures on the right, you're seeing the increased uptake in the hip. So laboratory values, we're looking at CRP, ESR, CBC, and blood cultures. Blood cultures are not always positive, but they can definitely help isolate an organism early. And they are positive in 30 to 50% of cases. And then certain factors can tell us whether it's more likely to be a MRSA infection. So looking at temperature, the white blood cell count, the hematocrit, and the CRP. The CRP is almost always elevated. It's the quickest to rise, and it begins to rise in about 6 to 8 hours. It peaks within 24 to 48 hours, and it can be utilized to follow the clinical course and the effectiveness of therapy and recovery. So trending a CRP after you start antibiotics can be very helpful. It's more sensitive than ESR or the white blood cell count. It's not very specific, but it is elevated in 98% of acute hematogenous osteomyelitis. The treatment is really antibiotics. It really is a medical condition. We do surgery when indicated, but always after starting antibiotics to see if that will effectively treat osteomyelitis. different than a subjoint osteomyelitis. Infectious disease is very helpful in getting them involved early because they are more aware of the endemic organisms and the antibiotic resistance in our area. So. And there are certain antibiotics that we typically start with based on the age group. And again, it's important to get the infectious disease team involved so they can help further guide this as well. When do we do surgery? When the antibiotic penetration into an infected site is impaired. So if there's a sequestrum, an abscess, if there's a pus on aspiration, which tells us there's a subperiosteal abscess, if there's an infection in the joint, we do surgery, and if they're not really responsive to the antibiotics after 36 to 48 hours. Okay, so discitis. So an infection in the disc of the spine, typically in kids less than 8, is a hematogenous seeding of the end plate typically, then it spreads into the adjacent disc, and it can spread further into the metastasis of the bone. Usually a little bit in older kids, but they refuse to walk. They may have back pain, and they're really holding their back in a different position, so they can't really flex forward, or they lose lumbar lordosis. You can see in this child on the right, it's a very straight lumbar spine. There's typically a lordosis to it. It's very straight. It may be essentially referred pain. They may really present with hip pain or abdominal pain or pain at night. But this is just to show that there can also be an infection in the spine as well. So ESR, it's mildly elevated. We can get blood cultures to look at it. An MRI is the most sensitive. Findings on x-rays don't really show up until about 2 to 4 weeks. And aspiration is typically positive on about 60%. But usually this is unnecessary, and we don't really aspirate unless their clinical picture is worsening despite antibiotics. Typically, they need antibiotics for at least 6 weeks. We may support them with a brace or a cast or bed rest. And then if they're not really responding to antibiotic treatment in 3 to 5 days, the infection may have spread to the epidural space, or did it spread somewhere else? All right, on to hip dysplasia. So we're going to go over some risk factors, the exam, ultrasound, and also the pelvic harness. And this is a schematic on the right of that picture. So some of the risk factors, the incidence is about 1 in 100. It's more common in the firstborn child. If the child is female, if there's a breech presentation or birth, if there's a family history of hip dysplasia, and other things causing essentially not enough space for the child, so oligohydramnios or a high birth weight. And then also a risk factor after birth is swaddling the legs in extension. You can see on the right here in B on the bottom where the legs are extended. Don't really want to do that for the health of the hips. And then actually race does play a role, and the rates of hip dysplasia are lower in Blacks. On exam, we want to look at a few different tests. So on the right is really showing the Galeazzi sign, so the different appearance of leg length discrepancy when you flex the knees. So one knee is higher than the other. It looks like one femur is longer, but it's really from the hip sitting dislocated in that position. So in the Barlow or Ortolani test, so Barlow, you're adducting the knees and trying to push the hip out the back, and then Ortolani, so trying to reduce the hip back in by abducting the hips and applying a posterior to anterior force. So if that clunk is positive on either one of those, that's what we refer to as a Barlow or Ortolani positive hip. We're looking at asymmetric or limited abductions in the bottom right picture. This child can abduct the right hip more than the left, and that's a sign of one of the hips being dislocated. And we're looking at asymmetric thigh folds, not so much the folds around the knee, but more around the hip if they seem asymmetric. And it wouldn't really be asymmetric if both of the hips are out, but that is something to look at. So we typically get an ultrasound Usually after 6 weeks, because if we get an ultrasound before 6 weeks, they can just show physiologic immaturity. If we think there could be hip dysplasia, but without a fully positive test, typically an ultrasound after 6 weeks gives us the most information. And then what we're looking for are these angles, the alpha angle and the beta angle, really measuring the angle of the acetabulum and looking for the coverage of the femoral head. So how much of the femoral head is covered by that acetabulum. And then this is usually followed up by an X-ray at 4 to 6 months. So at that time, the ossification center of the proximal femur starts to show up, and we can see the position of the hip on the X-ray at that time. So if there is hip dysplasia, we start with a pavlocornis, pictured on this baby on the right. And then if that fails, then we can go try an abduction brace. There are several shapes and brands and designs of abduction brace, but it's a more rigid brace to keep the hips abducted. The other thing to note about this pavlocornis, it is a dynamic brace. So you do want the kids going to kick and move around. We're just optimizing seating that femoral head in the acetabulum better. And I also included this website. So the International Hip Dysplasia Institute has a lot of really good resources on their website as well. I didn't get into more of the older treatment of hip dysplasia in the older kids. So just sticking with the NICU, I wouldn't imagine that any kid would need more than the harness or the abduction brace. Sometimes, I'll just go back for a second. Sometimes we do in the younger kids, we need to do a closed or an open hip reduction. But first line, we try those braces first. Okay, so going on to foot deformities, so different shapes of the foot. The schematic on the right here is just showing the different direction that the foot can go into and how to describe that. So showing the line down the center of the heel and where that bisector line intersects the toes can tell us which direction the foot is going into a more valgus position or into varying degrees of varus. So a cavus foot, so a higher arch of the foot, including club foot, cavovarus, equinovarus. There's also equinovalgus, however, too. Planus, so there's congenital vertical talus or calcaneovalgus foot. We can think of metatarsus adductus as more of a rotational deformity of the foot, and then toe deformities, syndactyly, polydactyly, curly toes, and macrodactyly. I'll go into a little bit of this. So clubfoot, it happens in about 1 in 1,000 children. Half are bilateral. In 80% of these kids, it's an isolated deformity, and it is more common in males than females. Despite 80% being an isolated deformity, there are other associated disorders that do include club feet. So arthrogryposis, diastrophic dysplasia, so a type of dwarfism, myelodysplasia, tibial hemimelia, amniotic band syndrome, Pierre-Robin, Opitz, Larsen syndrome, and Prune-Belly syndrome. And as a result of the foot being shaped like this, there is typically an anterior tibial artery hypoplasia or absence. So the blood flow to the foot is coming from the posterior. And it can be important when we're thinking about different surgeries that we sometimes need to do. And then we do need to be cognizant to make sure that we're not stretching those too much to maintain the blood flow. So Ponseti casting is the go-to, definitely the first-line treatment for clubfoot. It is successful in about 85% of idiopathic cases. Despite this, most need a tendo Achilles lengthening, but instead of what could be very extensive clubfoot surgery that our field did in the past, this has really negated a lot of the need for that. in most cases. I'm saving that more for the extreme cases that are resistant to this treatment. And on the right, you can see these are long leg casts, and from going left to the right, that's really the different progression of the foot that Ponseti described. And you can see it from the front and also from the side. So taking it from a varus position to a more valgus or abducted position, and then going from more equinus to a more neutral hindfoot position. And then also included the Ponseti website, the Ponseti info, that have also a lot of really good resources if you'd like to look into that a little bit more. And this is just a picture of a baby with two club foot casts on there. All right, metatarsus adductus. It happens in about 1 in 1,000 births. It's bilateral in about 50%. It's about equal male to female. And the risk factors are really related to intrauterine positioning. So some of the other risk factors, late pregnancy, a first pregnancy, if there's twins, or oligohydramnios. It is associated with developmental hip dysplasia, DDH, in 15 to 20%, and also associated with torticollis. 90% resolves by age 4. And we typically tailor the treatments to how flexible it is. So if it's very flexible and actively corrects, you can stimulate the foot and they move their toes and move the foot and it corrects past neutral, and we just observe. If it's passively correctable, so you can stretch the foot over neutral, we typically treat with serial stretching. And if it's more rigid with a medial crease, then we can start with serial casting. Excuse me. All right, calcaneovalgus foot. So this happens in about 1 in 1,000 births. It's a little more common in females or firstborn children. And really the treatment is first stretching. Sometimes we need to do casting. And there is a risk of later leg length discrepancy. So that leg is, it can be a bit shorter than the other side. And usually we don't ever really need to do any operative intervention, even though it can be quite striking to look at a foot that looks like this, but really the top of the foot is extended up and touch, and can be even touching the tibia, but it can be successfully treated conservatively. And this goes through, I have some examples of different foot deformities, which can look similar, but on in the first picture, that is that positional calcaneovalgus, so it is related to intrauterine positioning. And you can see that there's still a longitudinal arch, and also the foot can be plantar flexed. It may not go all the way initially, but the foot can be further plantar flexed. In the picture B, so that is showing what we describe as a rocker bottom foot. So that's congenital vertical talus, and the arch cannot be created by plantar flexing the foot. So you can't really flex it down as like the other the first picture. In C, you can see that this is actually the apex of the deformity is a little bit higher. It's not really the hind foot, but it's the distal tibia. And that is associated, so that is posterior medial tibial bowing. And in D, that is a paralytic calcaneovalgus, so that is associated with myelomeningocele, and that's more related to the different muscle tone, so weak plantar flexions in that child. A little bit more about congenital vertical talus. It is much more rare, so it is in 1 in 150,000 births. It's a bit more common in males and females, but 2 to 1. 50% are bilateral. What it really is, it's a dorsal dislocation of the navicular on the talus, so it's a midfoot break. It's a dislocation through the midfoot, and that's what gives that rocker bottom shape, very convex in the bottom of the foot. It can be idiopathic, but it is more often associated with another neuromuscular disorder or a chromosomal abnormality. It can be associated with myelomeningocele, arthrogryposis, diastatomelia, congenital hip dislocation, cerebral palsy, and spinal muscle atrophy. And we do want to get an MRI of the neuroaxial imaging, so to rule out any other underlying neurologic disorder in the brain and the spinal cord. And we do want to get X-rays. So the plantar flexion X-rays are helpful with essentially trying to force plantar flex the foot to see how much it reduces. And there is, we do casting. It is Dobbs casting, and the positioning the foot is really the reverse of Ponseti's positioning. So you're almost trying to put the foot into what seems to be more of a club foot position. They often do need a tendo Achilles lengthening. So even though the foot appears to be dorsiflex, the hind foot really isn't, and the forefoot is what's dorsiflex. So still the back of the ankle, that heel, still has a contracture of the Achilles. And sometimes we do have to do a talonavicular pinning, so reducing that joint and pinning it to hold it in place. Some toe deformities. Syndactyly, polydactyly, curly toes, macrodactyly. So syndactyly, if it's an isolated syndactyly of the second and third toes, it's basically normal. It's a cosmetic difference and it really has no functional consequence. Acrosyndactyly in the right picture, so that is caused by an amniotic band syndrome. So the toes developed, and there was apoptosis to cause a differentiation and separating of the toes, but the amniotic band caused the end of the toes to be together, so they formed all the way together at the end. And you can see that little stick between the toes. There is a full space between the toes, but then they're fused at the apex, or the apical end of the toes. Complex syndactyly. That is seen in Apert syndrome and the Greg's syndrome. That is an autosomal dominant disorder, and that is a combination of syndactyly and polydactyly, and it's soft tissue fusion, but also bony fusions that develop in the feet. Operative treatment really is very individualized and more related to any pain or calluses or extra prominence that are causing problems when walking. So although they may look very odd, the operative interventions are really only if it's causing an issue. Polydactyly, it happens in about 1 in 500 births. 34% also have hand polydactyly. You want to look for any upper limb or craniofacial deformities. There are different categories of polydactyly, so too many toes. So 9% are preaxial, so on the big toe side, and 85% are postaxial, or on the small toe side, the pinky toe, and 6% are central, so somewhere in the middle of the lesser toes. And there is a difference in different races. So the preaxial is more common in Caucasians, and postaxial is most common in African Americans. And we do want to get x-rays, typically standing x-rays. So we don't initially do anything for the polydactyly if they're very small. And we really operate if it's difficult to get them into the shoes. It just may be too wide when they're fitting into regular shoes. There is more commonly other limb deformities in the preaxial polydactyly. Okay, curly toes. So it's a congenital flexion and adduction and external rotation of the toe. On the right here, you can see it in the fourth toe. So it's kind of tucked under the third toe. So it's rotated, it's adducted, and it's flexed. It's a flexion contracture of the flexor digitorum longus or brevis. We don't always have to get imaging. The first line treatment is stretching, trying to stretch out that flexor tendon. and we operate to release that tendon. If in older children it becomes symptomatic, if it's causing issues with walking, they're tripping over it, it's causing pain when they're wearing a shoe, things like that. But macrodactyly is very rare. It's not clear how it happens or why it happens. It is associated with some other disorders, Proteus syndrome, Maffucci syndrome, Olier's disease, Milroy's disease. We do want to get x-rays to further characterize what parts are large and how that size is distributed through the digit. The operative interventions are very individualized and very creative because there is not a common shape to any of these. Some of the surgery options include some form of guided growth, so either causing a growth arrest, partial or full, depending on what bone is affected. Osteotomies, redirecting the bones, cutting them, shortening them, or sometimes amputations are the best option of either partial or that whole toe or a ray. So that is also very individualized to the character of the deformity. Couple spine topics. So torticollis, infantile scoliosis, congenital scoliosis. So on the right here, I have a picture of infantile scoliosis treated with casting, and you can see how the spine did correct and is straight there all the way on the right. Torticollis, most of the time it's muscular, and it is treated with stretching, and the things that you can look for, that head tilt toward the affected side, the chin points away, and you can feel that the sternocleidomastoid is more prominent and contracted. Differential diagnosis, so again, thinking about infection. If it's a fixed deformity and doesn't make it better with stretching, or it really can't be passively corrected at all, we want to think about congenital scoliosis, a tumor, or another underlying neurologic disorder. So most of the time it's muscular and it's treated with stretching. 90% improve in 1 year. You can see on the right here some instructions on how to work on some of that stretching that parents can do, or you can do in the NICU. If that doesn't work effectively, we can use what's called a pinless halo. It is attached to a halo vest, and it is a ring around the head with some pads that essentially try to push the head over without those the more invasive pins that do go through the skin. And then surgery, if really all of that fails to release that muscle. And it is important to address this fully, because if it does go on and the kid does get older, it does affect the development of the face and head if they're contracted in that off position for a very long time. Okay, so congenital scoliosis. So abnormalities in embryogenesis can cause different forms of congenital scoliosis, so that the spine segments develop differently. So it can be a problem with formation or segmentation, or assimilation or ossification. And each of those different embryologic steps, if one of them is abnormal, it can cause a different misshapen vertebrae. Such as a butterfly vertebrae or a block vertebrae or wedging or a hemivertebrae or Klippel-Feil syndrome, and that would be another congenital scoliosis. So infantile scoliosis, so not congenital, not that the bones are fully misshapen or half formed, but that there is a curve in children less than 3 years. It does make up 4% of idiopathic scoliosis. It's more common in males than females. It's more commonly a left thoracic curve, and there is typically there can be a family history of scoliosis. So the distinction here in infantile scoliosis is more common in males because Adolescent idiopathic scoliosis is more common in females, and typically in the adolescent idiopathic scoliosis, it's more commonly a right thoracic curve. So here it's a more commonly a left thoracic curve. It is associated with plagiocephaly, other congenital defects, neuroaxial abnormalities, thoracic insufficiency. We do want to get x-rays to further evaluate the spine. And we do definitely want to get an MRI to rule out a tethered cord, a cyst, a tumor, or a serings. And there's about a 20% incidence of one of these other neurologic structural abnormalities in the spine in kids with infantile scoliosis. And on the right here, I have a schematic of the rib phase. This is more of a prognostic indicator of the likelihood of the curve to resolve or really completely go away as the child ages, and it's related to the rib phase, so the relationship of the ribs to the vertebrae, and looking at that overlap in that angle. So if you want some more resources, the Scoliosis Research Society website has a lot of really good educational resources as well. Birth trauma, so fractures and brachial plexopathy. So more commonly, there's going to be, if there's a fracture, it's of the clavicle or humerus. And this also goes along with also injuring the brachial plexus. So injuries in that arm. On the top right, you can see a clavicle fracture that is already healing with abundant callus surrounding it. And the bottom, you can see a humerus fracture. On the right, we have two kids. You can see how their arms are essentially strapped to their abdomen as a baby form of a sling to immobilize the arm, and that's really appropriate for the clavicle fracture or the humerus fracture. The other differential diagnosis, so why are they not moving an arm? Does something feel different, warm, swollen? We want to think about infection. Is it a fracture? Is it a brachial plexopathy? So is there a nerve injury that's affecting use of that arm? We do want to get x-rays, so easy enough to get x-rays to first answer the question, is there a fracture somewhere? Want to get labs also to evaluate for, is this an infection? And then also a really focused exam to determine what part of the arm really isn't moving. Is it the shoulder? Is it the elbow? Is it the hand? Really, what part is the problem? So overall, brachial plexopathy happens about in 1 to 4 in every 1,000 births. It's either typically on the right side or bilateral. And the treatment is based on which nerves are involved and how severe it is. On the top right, you can see there's a grading scale, the active movement scale from the Hospital for Sick Children, developed in the hospital in Canada. It's describing different motions of the arm, and then with and without gravity, and that's scored. So it's a very detailed exam and grading scale to determine which nerves are involved in the severity of the brachial plexus injury. Some of the associated problems with it are glenohumeral dysplasia. So if the arm is not in the appropriate position and move around appropriately, just like the hip, the shoulder can develop abnormality and have dysplasia. There can be an elbow flexion contracture, again, because it's from the asymmetric muscle movement. Again, there could be clavicle or humerus fracture. So if you find a fracture, it doesn't mean that there isn't also a brachial plexus injury, and is associated with torticollis. Risk factors: macrosomia, multiparous, forceps delivery, so prolonged delivery needing assistance, breech, any prolonged labor. And you can see on the left here, that child is holding that left arm adducted and internally rotated, and the elbows extended. So we start with an x-ray, evaluate for any other fracture. Also on the chest x-ray, you can see if there's a hemidiaphragm elevation, and that would indicate that there's also phrenic nerve involvement. An MRI is sometimes helpful, sometimes very difficult to read, but that would be helpful in differentiating whether it's a root avulsion versus a more distal injury to the nerves. An EMG has poor reliability, but an ultrasound can also be helpful to assess for joint subluxation or dislocation. That asymmetric muscle tone that can affect the position of the joints as well. Erb's palsy is the most common, and it also has the best prognosis. It has about a 90% spontaneous recovery rate. So that's affecting C5 and 6. And so that's at the top of the brachial plexus, so more of a pulling down attraction. So that's usually why it affects the top. Klumpke's is C8 to T1, so a lower injury in the positioning of the hand or the claw hand. It's more rare to get to, but it might have a traction on the lower portion of the brachial plexus, total brachial plexopathy. So it affects motor and sensory, and it has the worst prognosis. And on the right, I have also the schematic of the brachial plexus. So where the injury is and which nerve roots and how severe it is really dictates the deficit and also the treatment. Okay, knee dislocation is very rare. It is associated with Larsen syndrome and myelomeningocele and arthrogryposis. It is associated with hip dysplasia. About half of these kids do have hip dysplasia as well. They can also have clubfoot or metatarsus adductus. Treatment is weekly splinting or casting to try to progressively flex the knee to reduce it. And because these kids typically do also have hip dysplasia, we do want to address the knees before addressing the hips, essentially to try to fit them into the pelvic harness. And we do surgery if we fail to achieve about 30 degrees of flexion after 3 months of casting. So that would be open reduction, and then we have to lengthen the quadriceps, for instance. And those are some of my other references that weren't sporadically included. And that's all I have. So thank you. And that's our website. You can follow our group on Instagram, and that's my email if you have any other questions or thoughts or anything afterwards as well.
All right. Thanks, Dr. Stelma. We have a few questions. First one, how do you differentiate between osteomyelitis and bone neoplasm?
That is a great question. So some of that, we do want to get labs that can help differentiate. The other thing to consider is that typically we think of treating infections very acutely, and we want to start by treating that. So if it's confusing at all and there's an acute response, we do want to treat it like it's an infection. Some of the characteristics on x-rays can both be confusing, but also can be characteristic of one or the other. So some of the where the lysis is there a mass somewhere that can sometimes show us a little bit of a difference. But then the other thing is surgically, if we do need to operate to decompress the infection. Anytime we do that, we send a sample for cultures, but then also to pathology, because there's always a question: is this really a tumor that we're degrading and thinking is an infection? So anything that we think is an infection, we also send to pathology, and the reverse is also true. Anytime someone's doing a dissection or a sample or biopsy for something that we think is a tumor, we typically also send it to the lab for cultures to assess if that's what's going on as well.
Okay. The next question, is a biopsy always necessary?
No. So if it looks if the clinical picture is very consistent with an acute osteomyelitis, the labs, the exam, the imaging, and by then we would have started antibiotics anyway, and they start to respond to it, then we can continue that treatment, and then typically trend labs, reassess them. So going an exam, is it clinically improving? Is the redness improving? Are they moving a limb more? In an older kid, are they walking on it again or moving the arm or hand or wherever it is? So no, it's not always a biopsy is not always necessary if the picture is more consistent with infection. If it's a more confusing picture, if it's ongoing, then we sometimes do a biopsy to help clear up that picture. And then also with blood cultures that we would have gotten, that can also, if those are positive, then we can also treat for that organism.
Okay. In surgery, do you remove the abscess, wash out, and fill in the bone?
So it really depends on where it is and how large it is. We can, if it's very small, we don't always have to fill it in with anything. And sometimes we really just leave a drain for a couple of days to also kind of drain out that space rather than trying to overpack it and close it up completely. We don't want it to recollect. Sometimes if it's larger, we have to put in antibiotics into the space locally. For more chronic things, sometimes we have to put in like a bone cement with antibiotics in it as well. So sometimes that's indicated, but it really does depend on where it is. And I'd say more often than not, we don't have to. Sometimes if we are debriding, let's say a subperiosteal abscess, and there is evidence of just a very diffuse osteomyelitis, not really an abscess within the bone, then we make essentially a cortical window, so a small window into the medullary cavity, and then can kind of debride into the medullary cavity using like Tourette's or something like that. It's no longer tool to get into that space without making a large bone defect.
Okay. Next question is a little bit longer. A patient found out she had hip dysplasia at the age of 34 once she started working out again during COVID due to pain in the hips. Orthopedic doctor diagnosed. After having her second child, she wanted to make sure the child didn't have any known signs. Child is 13 months old. It shows mildly shallow acetabula, and suggestion of slightly subluxed femoral heads. Early hip dysplasia is not excluded. No dislocation. Pediatric orthopedic follow-up is recommended. Is it too late to brace an infant once they are 13 to 14 months old?
Yeah. So usually in slightly older kids, we think about, I would have, it depends on exactly what the x-rays look like, but in older kids, that's when we start thinking about we might have to do a casting or surgery to increase the acetabular coverage over the femoral head. So a little bit depends on how bad it is. The braces are typically for kids that aren't really walking around yet. So in older kids, sometimes we have to employ some of those other strategies.
Okay, looks like we have one more here. Why is radial club hand treated with surgery instead of casting? What is different about the feat and the success of casting?
You know what? That I would actually have to defer to a pediatric hand specialist for the specific treatment of radial club hand. But as a general rule, the feet are a little bit different from the hand because of the demands of the hand, and the feet are different. That's one. So we need the hands to do a lot more, and they take different stresses than our feet.
All right. That's the last question that we have.
Okay. Hopefully that was helpful.
And it looks like we're just about at time. So if you have any closing comments, we can wrap up after that.
No, just thank you everybody for listening. If I didn't really answer some of your questions as well as you'd hope, I'm happy to follow up with you and find you some more detailed answers.
All right. Thank you, Dr. Stelma. On behalf of Atlantic Health System, Morristown Medical Hospital, Pediatric Orthopedics, I would like to thank you for your participation in today's event. You will now be redirected to the post-event survey requesting your feedback. Please take a moment to complete this survey to receive credit for providing feedback and attending today's webinar. This concludes today's stream. Thank you and have a great day.